Hi, my name is Lorraine Keller, and my research partner and friend is Teresa Ying, and we will be presenting to you our study today. But rather than start with the title of our study, we thought it would be more appropriate for us to start with explaining the motivation behind how the study started, and that is obesity. So I'm sure we all know, but obesity rates have quickly increased over the last few decades. And in fact, today it's estimated that 1/3 of our American adult population is obese. That is a lot of people, and a lot of people you will likely encounter in the operating room. Following the trend of obesity is the rates of bariatric surgery, obviously. American Society of Metabolic and Bariatric Surgery have estimated that since 2008, about 150,000 to 200,000 bariatric surgeries are performed on a yearly basis. So what do these statistics really mean to us? Well, first of all, obesity presents with a lot of physiologic changes that actually affects our anesthetic, most notably the respiratory system. And in fact, in bariatric surgery, it was noted that respiratory issues were the most common complication. Furthermore, postoperative pain management is particularly challenging because these patients are prone to sleep apnea and cardiopulmonary collapse when they're given high doses of opioid analgesics. So postoperative pain management is really a fine balance between achieving adequate pain relief while mitigating any risk of hemodynamic compromise. But opioids are really the mainstay analgesic still for perioperative scenes. And so attempting to figure out exactly how much opioid analgesic you can safely give your obese patient to ensure that they're comfortable and yet ensure that they're not underventilating or becoming hypoxic is extremely difficult. And so perhaps rather than debate the answer to this question, we should be asking a different question or approaching this issue in a different way. And so perhaps we should be asking, well, what non-opioid analgesics can we give our obese bariatric patients so that we can help them be comfortable, so that we can help them have optimal respiratory function, and ideally decrease the amount of opioid analgesics that they need? And these were really the questions and the reasoning behind how this whole study started. And I wish we could say that Teresa and I came up with these ideas, but it was not actually our original idea. It was Dr. Camporisi from Tampa General Hospital. And Dr. Camporisi is a very well-read and well-published anesthesiologist, so the whole idea behind this project was his. So here is the actual working title of our study: the systemic intraoperative lidocaine infusion for postoperative pain management in obese patients. So I'm going to start off by giving you 3 studies to give you a little background literature information. The first one is by McCarthy and colleagues. It's a systematic review of randomized control trials, and they actually looked at the use of lidocaine infusions in abdominal surgeries, cardiac surgeries, orthopedic surgeries, and tonsillectomies. They ended up reviewing 16 randomized control trials, which are shown right here. And their conclusions found that in abdominal surgery, lidocaine infusions during the perioperative period provided significant pain relief, reduced postoperative opioid consumption, decreased opioid-induced nausea and vomiting, promoted faster return of bowel function, and allowed for a shorter hospital stay for these patients. Coincidentally, these benefits were not demonstrated in the patients that had orthopedic surgery, cardiac surgery, or tonsillectomies, which was a very big point that Dr. Camporisi made to both Teresa and I. He stated, I found that in a lot of surgeries this helps, but there are some surgeries that the lidocaine infusions just does not work, so I don't know if this will work for the bariatric surgery population. Our second study is a meta-analysis by Merritt and colleagues, where they did look at just intravenous lidocaine infusions in abdominal surgery. They had 8 randomized control trials, which are right here. And they too found that during the perioperative period and postoperative period, if the patients were receiving intravenous lidocaine infusions, it decreased the duration of their ileus, it decreased the incidence of their nausea and vomiting, also of the severity of the pain, and the length of hospital stay. And the last study we'll go over is another meta-analysis that was published in the Canadian Journal of Anesthesia, which is why you see some French right there. But Vigneault and his colleagues looked at 29 studies, which are right here over 4 pages. And they also found that intravenous lidocaine infusions, when used as an anesthetic adjuvant during general anesthesia, had the potential to improve postoperative analgesia during abdominal surgeries. They went on to further say that they weren't comfortable recommending anything because dosage regimens had not been assessed and the safety of the lidocaine infusion had not been systematically evaluated by any study either. So I'm going to present to you our study in the PICO format. Our patient population is the obese patient undergoing laparoscopic Roux-en-Y gastric bypass surgery at Tampa General Hospital by Dr. Moore, our bariatric surgeon. These are our exclusion and inclusion criteria, so you have a little more detail about our patient population. And because our study was considered a pilot study, we had 20 for our sample size, which is a little smaller than normal, but it's adequate for a pilot study. Our intervention group received an intraoperative lidocaine infusion of 2 milligrams per kilogram per hour of total body weight. Our comparison group received a placebo, which was a dextrose infusion running at the same rate. And our outcome measurements were the visual analog scale that was measured at specific intervals, a safety assessment questionnaire, analgesic requirements as charted for the entire hospital stay for that patient, the length of stay of that patient, and the return of bowel function. So I'm going to go ahead and hand it off to my partner right now to finish off the presentation.